Hello, everyone. It's time for a new GYN Garage. My name's Ed Pavlik. I'm in Lexington, Kentucky. About 2 weeks past the end of the government shutdown, where the weather is in the low 40s and sunny. All the leaves have just about reached the ground here. We're getting ready for Thanksgiving, and we've put a great big dent in the live turkey population in the U.S. My colleague today is Frank.
Frank Lawton from London in the UK. It's getting colder here. We've just had our budget today. Our Chancellor has decided how much money the Labour government is going to take from us to spend on other things. It doesn't look too bad for the likes of us and our family, but all they're doing is moving the money around from what we're not actually earning very much. That's the problem. I think the British economy relies on selling things like insurance and banking. We don't actually produce stuff that people want to buy. And obviously the Chinese and the Japanese and the Germans do produce stuff that people want to buy. So anyway, enough of that. Enough of politics.
Well, I saw that too this morning, that the taxes are going up in the UK, and there's going to be new taxes on expensive homes. And there was a list of 43 different tax increases. So are they going to tax the wealthy more, or are the working folks like doctors and nurses, are they going to be taxed more?
Well, I think it's the Labour government has always talked about supporting working people, but they've never actually defined what a working person is. And I assume a working person is exactly the same as someone who sweeps the roads or who does neurosurgery for a living. And that's the problem. And I think they've tried to tax the people who seem to have a lot of money. I mean, we live in a very nice house in South London, but we've got lots and lots of property, but we don't have a lot of money. So if they suddenly come along and say, well, we're going to get this so-called mansion tax. This is not a mansion. This is a 5-bedroom house in London. A mansion is castles and deer in the park and this, that and the other. So I think that a lot of people who live in a house that's made a lot of money because of inflation and property, but don't actually have a lot of money, are going to suffer here. They're going to have to find some money from somewhere to pay this yearly mansion tax that the socialist government wants to bring in. In addition, tax on sugary drinks, Coca-Cola and Fanta, tax Taxman, isn't it? The Beatles song, Taxman. It's all that.
Well, it's not an unusual problem to be house rich and cash poor. It's that way in Australia. It's there where you are. It's here in this country, and that type of thing. And we just have to say, what are we going to do? We want to live in our house and we want to eat. So we have to figure out a way to do that. So well, today we're going to consider the question: does the length of surgery to chemotherapy, does that interval affect ovarian cancer outcomes? And answer to this question is approached in a paper titled "Timing Matters: Surgery to Chemotherapy Interval and Outcomes in Ovarian Cancer." This paper was published in the European Journal of Obstetrics and Gynecology and Reproductive Medicine. And this work investigates whether delayed adjuvant chemotherapy of less than 28 days, less than 35 days, or less than 42 days has an effect on overall survival or progression-free survival. Frank, give us your insights.
Okay. I mean, essentially, this is a paper about toxicity. Does the toxicity of surgery interfere with the timing of giving post-operative chemotherapy? In a way, if this was antibiotic, we'd say, well, of course, get the antibiotics in as soon as possible. We know that antibiotics will make a difference. When you arrive in the accident emergency room with a temperature and spots or whatever, get the antibiotics in. This could be septicemia. We know that. What we don't know, of course, because the majority of ovarian cancer cases are not curable, what is the impact of this apparent delay, if indeed there is a delay, that surgery produces from the point of view of giving chemotherapy. I think one of the problems with the papers is that they have assumed that surgery the timing of surgery has the same impact on the outcome. And obviously, whether or not it's primary surgery and then chemotherapy, or chemotherapy followed by intervention surgery by further chemotherapy, they are not the same starting points. A patient who's had, and as they say, 3 to 4 cycles of platinum-based chemotherapy before intervention surgery is not the same patient who's had primary surgery and then gets 6 to 8 cycles of chemotherapy. So I think they've confused the paper already by assuming that surgery is the starting point, and it is, but it's 2 different starting points from this point of view of the study. They've looked at time to commencing chemotherapy, and they've chosen arbitrarily, but I think not unreasonably, 4 weeks, 5 weeks and 6 weeks, 28, 35 and 42 days. Although there are no real data that suggests why that's important. And I think they have, in a way, just chosen these dates out of the hat. It would have been a better paper if there'd been an intention to treat. So how many patients that began with primary surgery ended up having chemotherapy within 28, 35 or 42 days of the surgery, or the other way around with intervention surgery. And also the total amount of chemotherapy that the patients have received before they had their surgery. It says 3 to 4 cycles. Why 3 to 4 cycles? If they'd said we need intervention surgery after cycle 3 and then started, I think it would have been a much stronger paper. The average time to starting chemotherapy is, in their paper, is 46 days, which is quite a lot, more than the 3 limits that they had. But there's no indication in the paper why these delays occurred. Did delays occur because of patient wishes? Chemotherapy was delayed because of physician problems? Was it following surgery? Was the surgery that they had at primary surgery more intense or different from the surgery they had at intervention surgery? And then in the end, the results that they produce actually are not, there's not a real difference. There's no significant increase in progression-free survival or overall survival, whether the cutoff is 28, 35 or 42 days. But they do say there is and I have to read this one, clinically relevant non-significant trend towards improved outcome when chemotherapy was started within 28 days. Now, I don't understand what they mean by clinically relevant but non-significant. If you're doing the statistics, it's either significant or it isn't. Clinically relevant, I can understand that, but it's making it a bit murky, the results that they have. And like everything else, they do a subgroup analysis, and they found that, strangely, that if it's less than 28, more than 28 days between surgery and treatment, the hazard ratio increases. It's twice the hazard ratio of dying, but only for stage 3A and 4B, or 3A to 4B disease. And it also affects overall survival, but not progression-free survival. And I don't really understand the difference, why it should affect one but not the other. As we've always said when we're reviewing papers, Ed, there are some problems with the annotation here. When in the paper where they say figures 1 and 2, I think it should be figures 2 and 3. But if there's something as simple as annotation as to where you're supposed to be looking at the paper, I always think there's a bit of obfuscation here. They're hiding something. They also, and quite rightly, and this I think it is important, they review the other papers, of which there are half a dozen or so, that have looked at very similar problems. And they highlight the bits, again, they select the data from the paper that says, oh, look, this looks as if it's important. But in general, the evidence that says the sooner you get chemotherapy, the better your survival or progression-free survival is, the better, is not particularly good. It should be better. That's what we rely on. Get the chemotherapy in as soon as possible, because chemotherapy is good for, but the data do not suggest this. And I think this paper fails because of that. What they should have done, it's a retrospective study, and I know that's what you're dealing with, but it would have been better if they said, this is what we intended to do, and this was the outcome. And I think that's where this paper particularly fails. I don't think it's added very much, apart from 171 cases, to our knowledge as to whether or not timing is important. I think it is. I think most people do believe it, but I don't think this paper shows anything about that at all.
Well, I'm totally in agreement with you, Frank. So my role now is to really be somewhat aggressive into why this appeared. It's a very, very important question. I don't minimize that.
I agree.
And I think it's fair to sort of use this outline of the question, which I will share. And the idea, and as you've already expressed, but to show it sort of more in a way of actually graphing it out, is that we're talking about really the end of surgery, which is a relatively exact point, and the delay then to the start of adjuvant chemotherapy, and that's in people who've had neoadjuvant, and also in people that have not. So we're talking about a delay that's related to this line, and it's either of 28, 35, or 42 days, or less than those type of things. And so, and the authors call this the time to chemotherapy. So, just as you pointed out, this delay in this case or the delay in this case can be caused by a variety of things. A person can get COVID. A person can also not be able to be scheduled. Anyway, it's important to examine the question, but to a certain extent, the delay can be longer or shorter based upon, very human factors like scheduling. So, that's sort of the way I look at what's going on. Now, a lot of what they say, as you've pointed out, is they feel it's significant in some clinical sense, but they're very open about the fact that statistically they can't find significance. Now, the 2 points I'll make about this is the one illustration that there's some significance clinically is this improvement in this particular graph for the grouping of less than 28 days, which does catch your attention. When they looked at it statistically, they found that they weren't getting a good answer that this was really significant. Now, probably the reason is they started with 197 people total, and then they've had to divide them up into these three groups, which is fine, except you've drastically reduced the number you're going to look at in the Kaplan-Meier. And even more serious than that is that if you want to do the subgroup analysis, N becomes even smaller for each one of those groups. So in the end, they have a problem with numbers, and perhaps they should have collaborated with somebody who is out of the Israeli system that could have provided more numbers for this retrospective analysis. The other thing that is bothersome to me is somewhat sophomoric in the sense that if you can see up here where my cursor is, their 28-day group is really up to 28 days. But then when they go to the next group that is up to 35 days includes the up to 28-day group. And then their last group, less than or equal to 42 days, goes up, including the 35-day and the 28-day group. These are not separate groups. There's some carryover in some sense that they're looking at. So I would have, I'm really aware of how prejudicial this is to the finding that they're trying to make clinically, that it's just clearly the 28-day group that presents an advantage. With that in mind, they have made some statements that I want to emphasize right here that the phenomenon did not reach statistical significance, yet the p-value that they use is clearly statistically significant at the zero point 0.1 level. I mean, it's just out of the 0.5 level, but it could be said to be significant, but for reasons that they chose, they said their findings did not, that I just showed you with that first Kaplan-Meier, did not reach significance. Now, they also throw in a second statistical tool, the Cox proportional hazards model, and there their finding is shown right here, that surgery to chemotherapy interval longer than 28 days was associated with more than a twofold increased hazard of death compared with treatment within 28 days. So the longer ones, are in a sense statistically, because the p is p 0.005, means that something that you don't want to happen happens after 28 days. And then the last thing that they say that has statistical significance is that primary debulking was associated with improved survival compared with neoadjuvant chemotherapy. That logically sort of stresses our imagination, because we're used to one thing, people pointing out that there's not necessarily a difference between these treatment approaches, or that it favors neoadjuvant. So in the end, there are things that have statistical relevancy are unusual. Now, the other thing that's unusual is if they compare late stage disease here with early stage disease, there's no significant effect with overall survival, which that's not the way any of us think, that late stage disease is survival after late stage disease is the same as for early stage disease. So once again, this is another conundrum in what they're reporting. When they really go into the subgroup and inspection, I think really they've run into that numbers wall, that they really didn't have enough numbers there. And then the ultimate statement that I've sort of already mentioned here is this highlight in yellow, a clinically relevant, non-significant trend. Frank has already pointed that out, and it's mysterious to me, really, what that means. Perhaps you can explain something, and then subgroup analysis on late versus early stage disease is pretty small to get a good Kaplan-Meier out of 19 or 20 folks is really stretching it. The impact factor of this journal is pretty low. Their site score is pretty low, but they're published by Elsevier, great publishing house, does a lot of scientific and medical stuff. So in the end, I think maybe this is a journal that ends up searching for reviewers and then getting somebody who really doesn't do a good job. There are words that were missing so that you didn't know what the sentence was about. As Frank has already said, you didn't know what was figure 1, figure 2, and there were no headings on the figures or tables. It was, very difficult to try and guesstimate what was going on in this paper. So that's all I have to say, Frank.
Yeah, I think you're right. I mean, it's a pity because, as we've said right from the start, this question is important. How quickly can you get chemotherapy in? Because let's face it, surgery alone, we all know, doesn't cure ovarian cancer. Surgery plus chemotherapy, there are a group of patients who do well. It seems logical that the sooner you get the chemotherapy in, the better the patient does. But I don't think this paper really has addressed that question particularly well. I don't think the statistics are very good, or the data, and rather like you, I think the numbers are small. Perhaps this is a study that should be either more centres doing exactly the same study, I think would be quite important. But I think right from the start, you've got to actually do intention to treat. It's no good saying these patients who did well were less than 28 or more than 35 or whatever it is. Is that what you intended to? Why did a patient who you should have had chemotherapy in 4 weeks take 6 weeks to get treatment. I think that's just as important, because otherwise people are going to say, we've got to get the chemotherapy in early, regardless of the outcome. Or more importantly, the surgeons might say, well, we better not do particularly radical surgery, because it may mean that this patient's treatment is compromised because she's not going to get her chemotherapy within this 28-day window. And I think that is completely wrong. That these data should not be interpreted like that, but perhaps they will be. I don't know. I think it's not a good paper. It's not good at all.
And in somewhat maybe the defense of things is they do point out, and I think you mentioned this, that everybody else who's published on this question has struggled with having a clear-cut answer, and the answer to go one way or the other. Either it makes no difference, or it does to go with the earlier treatment interval. But in the end, I'm going to say that really defends the fact that they needed to say. They could have said two things. A, because we really have so much faith in our ability to do things, we can get by with a smaller N than is really needed. And they had the expectation that we're going to do these things better than the other people have reported on it. They unfortunately didn't have that good luck for it to turn out that way. And so they've added another paper that has no statistical significance of note to the literature, and perhaps, if from a very positive standpoint, will become yet another signpost that this is an important question that's going to be very difficult to answer. So, well, that's a wrap. We've done it.
Yeah.
And you're going to have a birthday tomorrow, so I'll take or the day after tomorrow.
Day after tomorrow, yes.
So
yes.
I'm going to take the time to wish you a happy birthday.
Thank you very much.
And my present and punishment to you is that I want you to continue doing this, okay?
Wow, thank you. Whew, I wasn't expecting that. Yes, my wife and our family said, oh, what do you want for your birthday, Dad? And to be honest, it all sounds a bit soppy, just good health, and I'd like to see you all happy and whatever else. But apart from that, a bottle of champagne and a nice meal is probably pretty good for my birthday. I'm looking forward to it. I'll let you know next month.
Okay, very good. So we'll get together next month. I should be able to get the In the Know out soon, and in time to plan it.
Okay, that's fine. Sometime before Christmas would be great.
Okay, very good. You take care, Frank.
And you.
Bye-bye.